And Ménière syndrome is a complex of fluctuating hearing loss, typically starting in the low frequencies, while you're having episodes or attacks that can last anywhere from 20 minutes to hours to even days, which also include fullness in one side, or both ears if you have it in both ears, and a roaring sensation, a very mean form of tinnitus, along with room-spinning vertigo, nausea, and vomiting. Ménière syndrome is really a medical condition, and we try very hard to treat it without surgery before moving to surgery. We usually start with people keeping a diary. Say I have an attack. What happened 12 hours before that attack? So what we'll do is we'll connect them with a nutritionist, help them sort through what are the common triggers, how do they avoid those, how do they manage their diet. And most people need to eat differently and need to hydrate more to prevent those attacks. The next level would be to treat them medically, and we would start with what we call a diuretic. And that is something that actually reduces the amount of pressure in the inner ear. And this is oftentimes confusing for people. We're trying to decrease the amount of inner ear fluid that we're generating, but at the same time, we don't want you to get dehydrated. So while you're taking a diuretic, we want you to continue to drink and stay hydrated because they are two different fluid compartments between your blood flow and the inner ear. We will often use some medications to break attacks in the benzodiazepine drug class, so the Valium or Klonopin drug class, and we have people carry those to break attacks, and you can have migraine vertigo without ever having a migraine headache. Now that you've gone through the medical treatment of Ménière syndrome, the next level are what are the surgical options. The first surgical option is to inject a substance into your middle ear through your eardrum, just in the clinic setting. One substance is a steroid and the other is a aminoglycoside antibiotic called gentamicin. The steroid is designed to not destroy the ear at all, but to decrease the inflammation that could be causing your Ménière's attack. This is something we use to break an acute attack in people who are extremely sick and we just need to get them over their current episode. Gentamicin is actually designed, just like a surgical operation, to clip the nerve. It kills the hair cells selectively in the inner ear that gives you balance. And when you look at the model of the ear, your ear is broken down into the cochlea, which gives you hearing, and the semicircular canals and the gravity sensors, the otoliths, which give you balance. And so we put gentamicin in, and it preferentially attacks this side of the inner ear, and we do it in a titration. So we give you more and more gentamicin, up to 3 doses actually, to get you to stop having attacks. You may still have 1 or 2 attacks a year. We consider that livable, but we really start using gentamicin when people are having multiple attacks a month or sometimes even multiple attacks a week. I consider those both surgical options because we're putting a needle through your ear under a microscope in clinic to treat you. And we typically will treat you up to 3 doses with those before we start tapering off to prevent any complication. The surgical treatment of Ménière syndrome is not used very often, and the only hearing preservation approach is to go in through the mastoid cavity, and we come behind the ear. And if you look behind the ear on the brain side, there's a fold in the dura of your intracranial cavity where your brain sits that actually generates and releases the fluid that takes care of your inner ear. And the theory of Ménière syndrome is the inner ear gets an increased fluid pressure that we need to manage. But you can actually go through the mastoid bone, which comes up against this area from behind, and you can drill the endolymphatic sac open so that it's free to move and expand within the middle ear. The thought is that by allowing it to expand, if the fluid increases, it doesn't increase the inner ear pressure and it prevents you from getting a Ménière's attack. The next level is to actually go in surgically and cut the balance nerves while leaving the auditory or hearing nerve intact. That's called a vestibular nerve section, and we would consider this in a patient who has significant Ménière's attacks but good hearing. We can do the middle fossa approach to cut those nerves, or we can actually drill through the mastoid, getting to those nerves to cut them. That is very definitive, and we only want to do that if people have very significant disease and have done everything they can to manage it medically before we get there. The gold standard is to just drill the inner ear out. Coming through the mastoid, we come in and we drill the balance portion of the inner ear. This will remove any hearing you have left in your ear, but it basically removes the ability for this ear to generate a Ménière's vertigo attack. That's called a labyrinthectomy. So again, medical management, physical therapy, dietary management, injectable steroids, injectable gentamicin or aminoglycoside antibiotics, endolymphatic sac if we're trying to preserve hearing, nerve section if we're trying to preserve hearing, and labyrinthectomy if we're going to remove the hearing and remove the vertigo attacks.